some stuff from the previous course, if you took 210 here, and we'll talk about diffusion. Now, if you recall, diffusion is basically, all right, where you have a substance in greater concentration in one area compared to another area. And so this creates what we call a concentration gradient. And so that substance is going to want to go from an area of high concentration to an area of low concentration. So when we're dealing with our respiratory gases, for example, oxygen, carbon dioxide, okay, so oxygen will want to go from an oxygen-rich blood source, let's say, maybe into an oxygen-poor tissue mass. So like exercising muscle, for example, has an increased oxygen demand, and so blood flow increases to that tissue, and that blood that's coming in is oxygen-rich, so the oxygen will move from the bloodstream, it'll diffuse across the cell membranes there, and it'll go right into the exercising tissue, in this case, let's say skeletal muscle, and it'll move right into that tissue there, so we can utilize oxygen for cellular aerobic respiration. So the same thing with carbon dioxide, vice versa. When those tissues are exercising, they're creating waste products, and carbon dioxide is a respiratory waste gas. So that exercising tissue is going to be in higher concentration with carbon dioxide. So carbon dioxide will leave the tissue and go into the blood because it's in lower concentration there. So basic concept, but now we're going to be applying it to some of our systems here. All right, so big issues when we're dealing with our diffusion is the route is going to really be dependent upon, all right, the size of whatever it is that is diffusing. So small solutes, those respiratory gases that I was just talking to you about, they have a relatively easy opportunity with diffusion because they're so small. If you recall, when we talked about it in chapter 4, they can diffuse through the cell membrane. Okay, something that allows for diffusion. All right, well, two properties that a substance has to have in order to move directly through the plasma membrane of a cell is it has to be one, small, and non-polar. So that's what we see with oxygen and carbon dioxide. All right, oxygen and carbon dioxide are very small, non-polar, so they move right through the cell membranes there. Now, with our larger solutes, okay, that becomes a little bit more difficult. Proteins are a great example. So proteins can't really get through the cell membrane there, and so they need help. So in situations like this, all right, our bodies have the capillaries, which are the smallest of the blood vessels. They'll have, all right, little slits in them, what we call fenestrations, or they'll just have these gaps, right, in which we call sinusoids. So we've just put these big holes, I shouldn't say big holes, but we just put these holes in the barrier there. In this case, it would be the capillaries. So those larger solutes can just pass right through those. So the other concept that I want to revisit is the vesicular transport. If you recall, pinocytosis and exocytosis, all right, these were both, all right, active transport processes here. And so when we're talking about pinocytosis, right, we nickname that cell drinking. And so pinocytosis is when there's a substance, usually on the outside of a cell. And so what the cell will do, because it wants this substance, a liquid in most cases, right, it will extend the plasma membrane out and surround whatever that substance is. So here's your cell, here's that substance here. And so what will happen is the cell will start to move that plasma membrane out and around that substance there, almost like a Pac-Man kind of thing. And so it'll pull it in, and then it'll bring the content into the interior of the cell. And so with exocytosis, I tell folks the first two letters of exocytosis is EX, just like exit. So this process is going to move substances from the inside of the cell to the outside of the cell. And so a lot of this, when we talk about vesicular transport here with pinocytosis and exocytosis, we are going to move things, all right, either from outside the cell to the inside, or vice versa, from the inside of the cell to the outside. And so this moves basically in both directions. And since we're talking about the circulatory system, basically what I'm telling you is, okay, this is some of the ways that we can move things in and out of our circulatory system. So hormones are a great substance that fit into this category, and then fatty acids. And we'll talk more about fatty acid metabolism and transport in some later chapters here. Okay, so keep that in mind as we move through. All right, let's get to something that's really going to blow your minds, and that's bulk flow. All right, now bulk flow, right, this is a huge concept here that we're going to be discussing for this chapter. So when we're dealing with bulk flow, again, we're going to be dealing with fluid substances, but now instead of a concentration gradient, we're going to deal with a different kind of gradient. We're going to deal with what's called a pressure gradient. Similar type of situation, right, in which we're going to move down a gradient. So in this case, when we're talking about bulk flow, we're going to be moving fluids down the pressure gradient. So we'll have two areas. One area will be an area of high pressure. The other area will be an area of low pressure. So what will happen is these fluids will go from the area of greater pressure to an area of lower pressure. Right? So we'll include the fluids, but of course in our blood, and we talked about this before, your blood has a lot of dissolved substances inside of it. So the fluid and whatever those dissolved substances may be will move from an area of high pressure to low pressure. And so we'll talk about, all right, these pressures because it's based on what we call our net pressure, because you're going to see here in a moment that when we're dealing with our blood, our circulatory system here, right, we have opposing pressures. That means we have pressures that are on the inside of a blood vessel pushing, trying to get out. And you also have pressures that are on the outside of the blood vessel pushing to get into the blood vessel. And not only that, now I'm going to throw something else at you. We're also going to be having some forces that have like a pulling force. So you'll have some substances on the inside of a blood vessel that are going to be pulling things into the blood vessel. We'll talk about all that. So let's talk about these two terms that are here that you see listed on the screen, filtration and reabsorption. Right? So filtration is going to move a fluid out of the blood. That's simple. Okay, so it's like your pipes in your wall. Right? What happens if you get a hole in the pipe? Water goes from the inside of the pipe to the outside. It's leaking out. And that's what we're going to see here with filtration. Fluid is going to want to move out of the blood. All right, so what we'll see is obviously something that's fluid-like, okay, like your blood plasma, or something that's really small, okay, that can move out of your blood vessels, the capillaries. Right, if there are openings. Remember, I was telling you about there's certain capillaries. There's 3 different types of capillaries that you have in your body. And so the last 2 in the category, you have capillaries that have these fenestrations, like these slits in them. And then you'll have some capillaries that'll have what we call sinusoids. And they're like a larger gap. And so these openings here will allow fluid mainly, and anything that's usually dissolved in that fluid, all right, those solutes there, to move out through those holes. But the nice thing is that the large solutes are blocked. Well, what's an example of a large solute? Well, how about a red blood cell? How about white blood cell? How about proteins? Okay, so we want to keep those in those blood vessels here. So we're going to normally see filtration at the arterial end of a capillary. Because if you think about it, a capillary is going to be these blood vessels that are found in between your arteries and your veins. So you'll see a certain kind of mixing of blood. Think of capillaries as an exchange site, right, where things are going to move in between your circulatory system and your tissues here. So at the beginning part of that exchange site, that's the arterial end, right? That's where we're going to see the filtration. And then at the other end of your capillary, that's going to be towards the venous end. Right? That's where we're going to see this next term, resorption. And that's when the fluid, say out in your tissues, is going to try to move back into the blood. Okay, so filtration is going to move stuff out of the blood. Resorption is going to move stuff into the blood. Right? So filtration at the arterial end and resorption at our venous end. All right, so let's talk about hydrostatic pressure. This is going to go back to what I was discussing with the pipes in your walls here. right? The hydrostatic pressure is that pressure that's exerted by a fluid on the inside of a pipe. And so, like I said, if that pipe is weak, then you can get a hole and that fluid will pour out of the pipe. Same thing here, all right? So when we're talking about hydrostatic pressure, this is that force that's exerted by a fluid that's going to try to leave your blood vessel here. So when we label it, we call it HP with the subscript of B, meaning that is the hydrostatic pressure in the blood vessel, in your blood. So this is going to be the force of that fluid on the vessel wall. And so this is going to help with filtration, because remember, it's pushing on the wall, it's trying to get out. And so when we go talk about filtration, filtration is going to be that movement of fluid, right, from the inside of the blood vessel, trying to leave the blood. So another type of hydrostatic pressure is the hydrostatic pressure exerted on the interstitial fluid. So the interstitial fluid is that fluid in the tissues. And so when we talk about the interstitial fluid hydrostatic pressure, this is going to be that pressure, all right, exerted by the interstitial fluid on the outside of the blood vessel, trying to push inwards on that blood vessel. Important thing to know is that pretty much in most of our tissues, the value of that is 0. In a normal, healthy individual, in most of the tissues. Now, there'll be situations in which that changes. For example, if you sprain your ankle and your ankle starts to swell, fluid is leaking out, right, into the interstitial, into those tissues there. Okay, so now you have this fluid that wasn't there before, and it's going to push on the blood vessels, and it's going to try to, some of it will try to leak back in. But in normal individuals, as you're sitting here, right, you're going to have pretty much for most of your tissues, your interstitial fluid hydrostatic pressure should be 0. All right, so now let's talk about our colloid osmotic pressure, also known as the oncotic pressure. So colloid, when you see colloid, you should be thinking of proteins. And then when you see osmotic, you should be thinking of water. Osmosis only has to do with the movement of water. So anytime you see osmosis, and there's a question on it, and they don't mention water at all, okay, then it's not osmosis. Okay? It has to do with water. So the colloid osmotic pressure is going to be this attractive force that proteins have. Keep in mind that water is an incredible follower, gives into peer pressure relatively easily, follows sodium all the time. If your kidneys are getting rid of sodium and filtering sodium out, water is going to follow it. And so it'll go into your urine. Same thing with sugar, glucose. Water loves to follow glucose. That's why people with diabetes have to pee all the time, because they're leaking glucose into their urine. And so as it leaks into the urine, water is going to follow it into the urine, so they pee all the time. So colloid osmotic pressure is this pulling attractive force, right, that proteins have on water. So when we talk about the blood colloid osmotic pressure, right, that's just telling us that you have these proteins in your blood. And so they have this pulling attractive force. And so they're going to try to pull water into the blood. Okay, so they're going to try to draw fluid into the blood because of those proteins. Albumins are a huge classification of drugs that do that. Your liver makes those. And so if there is liver dysfunction, for example, that's going to compromise your albumin level. And so what can happen then is if you lose part of your albumins in circulation, your blood will not be attracting water as much as it used to. And so that means the water might stay into some of your tissues, so you might get some swelling there. So our blood colloid osmotic pressure is going to promote resorption. All right, so think of it as going head to head with hydrostatic pressure. And we say that the hydrostatic pressure is dominant because the value of the hydrostatic pressure in your blood vessel is much higher than the blood colloid osmotic pressure inside of your blood vessel. All right, the next type of pressure is going to be the interstitial fluid colloid osmotic pressure. Say that real fast. right? Now, this is basically telling us, okay, that the proteins that are in the interstitial fluid are going to have an attractive force on water. So they're going to try to pull fluid into the interstitial fluid. Right? This is a very low value, roughly about 5 millimeters of mercury at the most. Right? It can range anywhere from 0 to 5 millimeters of mercury. So you can see it's not that high, and as it should be, because you really shouldn't have, right, a lot of proteins in the interstitial fluid. Right? They should be remaining in your blood vessels and inside the actual cells themselves, the tissues there. So it's not so much in the interstitial fluid. And just to let you know, the interstitial fluid is a compartment outside of the cells and outside of the blood vessels. Right? So that's, you have your blood vessel here, okay? Then you've got your cell here. So your interstitial fluid is going to be in between here. It's literally in between the cells. They're not inside the cells. If we're talking about the fluid inside the cell, that is the intracellular fluid. Okay, so now we're going to calculate what we call the net filtration pressure. Of course, you know, we're dealing with filtration. That means we are going to be talking about fluid moving out of the blood and into the interstitial fluid here. So the net filtration, right, we're talking about that. We're going to be discussing the difference between the overall hydrostatic pressure and the overall colloid osmotic pressure. So you want to memorize this formula listed here. So NFP, net filtration pressure, is going to be, okay, the difference between the hydrostatic pressure in your blood and the hydrostatic pressure in the interstitial fluid. And then we're going to subtract from whatever that value is, the difference of your colloid osmotic pressure in the blood and the colloid osmotic pressure in the interstitial fluid. And so we'll subtract your colloid osmotic pressure from your overall hydrostatic pressure. And so that's how we're going to get our net hydrostatic pressure. So we'll add both of those values up and then take the difference from them. So as we move from the arterial end of the capillary towards the venous end, that net filtration pressure is going to change. And normally it decreases because in the beginning at the arterial end, we want to get stuff out of the blood and get it into the tissues there. Because maybe you need some oxygen there, or maybe you need some nutrients in the blood. So we want to get it out of the blood. Then as we move to the other end of our capillary bed, okay, towards the venous end, that pressure starts to drop off because we're going to start to take, all right, stuff from the cells and bring them back into the circulatory system so we can circulate it out to different organs in your circulatory system. Maybe we want to oxygenate the blood. So we're going to send that deoxygenated blood up to the lungs so you can exchange that for some oxygen so we can oxygenate the blood. So this part at the bottom of the page here, at the arterial end, our net filtration pressure is going to be in favor of filtration, meaning we're going to be moving stuff from your blood into the tissues. Then we get to the venous end, it's going to favor resorption, meaning we're going to be bringing, okay, stuff from the tissues into the circulatory system, into the blood vessel there. So this picture here says it all. All right, so here you can see we've got our arterial here and then our venule over here. So oxygenated blood, blood that's loaded with delicious nutrients, okay, that your tissues need. And then over here on the right side of our screen, deoxygenated blood, right, and we'll have less nutrients in the blood over here. So you can see as we move from the left side of the screen to the right, here's our capillary. And so when we're measuring the pressures here on the arterial end, right, you can see here, for example, our hydrostatic pressure for the blood is going to be 35 millimeters of mercury. And then we will take the net hydrostatic pressure of the interstitial fluid, which is normally going to be 0. So the difference, if you subtract 0 from 35, you're going to wind up with 35. And then we're going to calculate out our osmotic pressure, right, the colloid osmotic pressure. So we'll take our values. We have 26, right, for the blood, and then 5 millimeters of mercury for the interstitial fluid. So we'll take the difference of that, which is 21. So we'll take 35 millimeters of mercury, subtract 21 from it, and we get a positive 14 millimeters of mercury, which means, right, net filtration is occurring outwards. We're favoring filtration. We're moving stuff from inside the capillary into the tissues. But now as we get over here to the right side of our screen, you'll notice that the hydrostatic pressure drops significantly in our blood vessel here. So we go from about 35 to 16. So then we calculate it the same way. We're going to take that difference here, 16, okay, minus 0, because again, right, the hydrostatic pressure doesn't really change in the tissues. So that's still going to have roughly a value of 0. All right, we're going to assume that this is a normal, healthy individual. Everything's going okay. So you have 16 millimeters of mercury is our value for the net hydrostatic pressure. And then we calculate out the oncotic pressure, right, both inside the blood vessel and outside the blood vessel in the tissue. And we get our 26 value, right, for the blood value of the oncotic pressure, and then 5 for the interstitial oncotic pressure. Take the difference there, 21. So 16 millimeters of mercury, subtract 21 from that, we get a negative value, negative 5 millimeters of mercury. And that tells us that resorption is favored. So our net filtration pressure is going from the tissues into the blood vessel, which is what we want. All right, so we should talk about the lymphatic system here because we don't talk about it enough and folks don't really, I talk to a lot of folks, a lot of my patients, people in general just don't understand what the purpose of the lymphatic system is. And I tell them it's the sewer system of your body. I mean, it's a little bit more involved in that. But the lymphatic system, its job is to go around, well, it doesn't go around, it's just located in places. And its job is to just pick up extra fluid that is sitting out in your tissues. Okay, this extra fluid was not resorbed. And so we have another system here. Okay, instead of our circulatory system, we have our lymphatic system. And so what it will do is it will resorb some of that fluid that wasn't resorbed by the capillary. And so that fluid enters into the lymphatic system and it circulates throughout the lymphatic system. And as it does so, it's going to get filtered. Right? We have different organs, your lymph nodes, you've got your spleen, right? So we have these lymphatic organs that are going to filter that fluid, and eventually it's going to dump all of that lymph that is in the lymphatic system back into your circulatory system, into the venous circulation up near the heart. So in lab, you go over, you're going to learn about the thoracic ducts, right? And you're going to learn about some of these larger lymphatic system parts and pieces. And you'll see how the lymphatic system is going to dump the lymph back into circulation. Right? But again, it's been filtered. A lot of it has been filtered. And a lot of that is part of the immune system because you're getting this stuff that was sitting out in the tissues. It doesn't necessarily have to be fluid. It might be bacteria. It could be a virus. Who knows what it could be? It could be anything. And so it's sitting out in the tissues there. It moves into the lymphatic system and it circulates throughout the lymphatic system. It goes through several lymph nodes. It goes through the spleen and it's getting monitored by your white blood cells. And if they recognize it as non-self or foreign, then it's going to invoke the immune response. So it's really kind of a cool system here. All right. So more on the lymphatic system in another chapter here, but we're going to now move back into blood flow here. We're going to talk about what we call local blood flow. So something you have to understand is, remember I said, our capillaries are the exchange sites between our circulatory system and our blood vessel, and our tissues here. And so what we should understand is not all of these capillary beds are going to be full of blood, because some areas might need, or some tissues might need blood more than others. And so it's really going to depend on the need, right, specific to those tissues here. So that local blood flow will change. It'll vary. It could be different in your arm compared to in your legs. So when we talk about local blood flow, first of all, we're going to be dealing with volume and time. So our local blood flow, basic blood flow, is measured in milliliters per minute. And so essentially what we need to make sure that we're doing with local blood flow or any type of blood flow is to make sure that the tissues that the circulatory system, these capillaries, are going to be supplying, we got to make sure that those tissues are getting enough of what they need. And so we call that perfusion. Okay, so that blood supply going to a tissue area, we want to make sure that it's getting enough of the nutrients, of whatever the blood is carrying, to help with metabolic function. So when we're dealing with local blood flow, we have to make sure it's high enough to maintain what we call adequate perfusion. So it's getting enough of what it needs. So when we're dealing with local blood flow, we're going to talk about a couple of factors. All right, one, how much blood vessels are in that area, all right, for that tissue. Okay, we call it the degree of tissue vascularity. All right, two, what we call the myogenic response. Myo, think muscle. So we're going to be dealing with some sort of muscle tissue here. All right, the third one is local regulatory factors altering the blood flow. And we'll discuss that. And then finally, what we call total blood flow. Now I'm going to get through some of these today for this chat session, but I won't be able to get through all of them. But no worries, I've got videos on that. It'll blow your mind. All right, so let's start off with the first one called, the degree of vascularization. And like I said, it really depends on just how much or how many of these blood vessels are going to be present in a given tissue. And usually, like I said, it's on a need basis. So tissues that have high metabolism demands, they're very active tissues, are going to have lots of blood vessels. Okay, so think about your skeletal muscle, your heart, for example. I mean, that thing's working all the time, 24/7, right? Liver, brain, all of these different tissues, right, are going to be highly vascularized because the brain gets top billing because it's the brain, all right? And so the brain gets what the brain wants. So we're going to see lots of blood vessels in that area there. All right, now other tissues, okay, again, will have very little vascularity, or in some cases are avascular. For example, famous tissue that's avascular is mature cartilage. All right, mature cartilage does not have a blood supply there. But you can see from this list here, tendons and ligaments, we know those are both dense regular connective tissue. Dense regular connective tissue has a very low degree of vascularity. Epithelia, same thing. It is avascular. All right, cartilage, mentioned that. The cornea and the lens of your eye, those are all going to have, all right, a decreased amount of vascularity there. So this term up here, angiogenesis, right? Angio has to do with blood vessels, and then genesis is the creation or to make, right? So angiogenesis is the formation of new blood vessels. And so we'll see in situations here, right? Again, certain tissues will say, hey, I need more blood coming to this area. I'm just not getting enough. Your body's like, no problem. I'm going to handle this. I'm going to send out some supply lines to you, right? And so basically what will happen is your body will start to create more blood vessels to a given tissue. And when it does so, it helps to increase perfusion. So you'll see all the time, right? Athletes, for example, that are going to be developing their skeletal muscle. You'll see they'll be doing a lot of training, all right? Especially when we're dealing with aerobic training, right? That means we're going to be needing lots of oxygen. And so you'll start to see, right, these athletes start to develop, right, tons of blood vessels. You'll see it in weightlifters all the time, right? Because they're developing those muscle tissues, right? They're getting bigger and they have more actin and myosin cross bridge formation occurring in those vessels there, sorry, in that tissue. And so we need to get blood to those tissues there. Right? Same thing with adipose tissue. Keep in mind, adipose, right, has several functions: cushioning, insulation, but primarily it's an energy reserve. And so it's stored energy. So when you need to utilize that stored energy, all right, we might have to ship that fat, those lipids, okay, to a completely different area in your body. So to do that, we need lots of blood vessels to those areas, right? And most of us have heard about what happens in the heart, right, when you get blockages. Some of those coronary vessels there that get blocked, they'll start to create little branches that are going to go to those areas of the heart, all right, that aren't getting enough blood because of the blocked blood vessels preventing adequate perfusion there. So it's just like, if anything, what goes up must come down. So with angiogenesis, we're going to create more blood vessels. Well, now let's say that athlete is no longer competing anymore. And so they're not trained like they used to. So they're going to enter into regression. And so what will happen is now we're just going to go back to the previous state of those blood vessels, because we no longer have that increased demand on the metabolic tissues there of the skeletal muscles. So we'll go back to the beginning there. And the same thing with adipose tissue, right? Maybe somebody has gained a lot of weight because they were sick or injured. And so they get healthy again and they start to lose that weight. And so they no longer have all that adipose tissue there. So what will happen is they don't need those blood vessels to supply that tissue because it's no longer present or as much. And so the blood vessels in that area start to regress and eventually go away. So this brings us to our first clinical view when we talk about tumor angiogenesis. And a lot of us have heard about this concept here, how when you get these cancer cells, and cancer cells are like any other type of cell, they need to eat, okay? And so they need nutrients. And so what cancer cells will do is they're really, really clever. They will start to secrete, right, these specialized molecules and these what we call cytokines, these chemical factors here. And so they'll release these chemical growth factors that will stimulate the body to actually make, all right, blood vessels that will come to those cancerous cells so they can start to grow in an uncontrolled rate. So a lot of research is in that direction of trying to get the drugs to be made that will prevent the formation of these chemicals. So it prevents those tumor cells then from getting the blood vessels to supply them, and then they pretty much starve. All right, let me talk about the myogenic response here. Okay, remember what I said, myogenic, myo is muscle. So of course, if we're dealing with blood vessels, we're going to be dealing with smooth muscle, because smooth muscle likes to line blood vessel walls here. And so when we're dealing with the myogenic response, all right, we're talking about how smooth muscle cells, right, that are found within the blood vessel walls are going to control the amount of blood flowing through that blood vessel. And so this is going to be a local flow, all right, but its job is to keep things constant and consistent. So let me throw a couple scenarios at you. Let's talk about systemic blood pressure. You go in to your doctor and they put the cuff on your arm and they're measuring your blood pressure. They're measuring your systemic blood pressure. So in this scenario, we're going to see your blood pressure rises. And when the blood pressure rises, we all know the normal blood pressure range is 140/90. That's the high end. The low end is 90/60. So say your blood pressure is 160/90. It's elevated, okay? So what we're going to see is more blood is going to be entering into your arterial system, into the arterioles there. And as more blood is present, it will push on the walls of those blood vessels, and so it will increase the stretch on the vessel wall. So the smooth muscles in the vessel wall, in the arteriole, will start to contract. And so when they contract, right, what that will do is that will help to decrease, right, the amount of flow in that area. And so that will start to return that normal blood flow, okay, to the original levels there. So let's flip it. Let's talk about when your blood pressure drops. So it goes below 90/60. Let's say it's 70/40. That's pretty low, okay? Not good. All right, so when that decreases, now there's less blood flowing through the blood vessels there, and so there'll be a decrease in the amount of stretch on the blood vessel walls there. And so as a result, what will happen is the smooth muscle cells will start to relax because there's less stretch there. And as they relax, the blood vessel will also relax and it will vasodilate. And so again, that will cause, all right, that amount of blood flow through that area to return back to the original levels here. So that's the myogenic response. So when we're talking about our local and our short-term regulation here, all right, we're on, let's see, I don't want to lose count here. All right, so we're on to number 3 here, the local regulatory factors altering our blood flow. So now we're going to talk about, all right, chemicals. Who doesn't like to talk about chemistry? So when we're dealing here with our locally regulated blood flow, there's a couple factors that play a role. One is, like I said before, this is going to be based on need. Certain tissues have a higher need, certain tissues have a lower need. Again, this will all be, I won't say 100% dependent on the metabolic activity, but the metabolic activity of those tissues play a big role. So some tissues, if they're highly active, their metabolic need will be increased, or if the tissue is damaged there. So we have what we call vasoactive chemicals. Again, these chemicals are going to be released by the cells here. And so these chemicals are going to change the blood flow, depending on what type of chemical is released. So a certain class we have are called vasodilators. And so if you look at the name, okay, what they're going to do is they're going to cause dilation of the arterioles. And so what that will do is that will increase the amount of blood flow into the capillary beds. I'll show you a picture here in a second, okay? Then of course our vasoconstrictors, that will cause constriction. And so the lumen of the arterioles will decrease. And so that will decrease the flow of blood into the capillary beds. So let's see, I got a picture in here. Where are you? Oh, I don't have it. You know what it is? That picture's in lab. Oh, I'm bummed. And I would try to draw it for you. Here's the arteriole. Here's the venule. And then, of course, you have the capillary bed in between here. So when we're dealing with our constrictors, all right, what we'll see is instead of the blood vessel wall being this big, it'll now be just this big here. So that decreases blood flow. And then in the beginning of the capillary bed, you have smooth muscle cells and they'll clamp down here. And so basically they'll increase the resistance. And if they increase the resistance, they'll decrease the blood flow there. And then the vice versa when it comes to the vasodilators. The vasodilators will make the arteriole nice and big. And what we'll see here is all that blood can flow right into our capillary bed. And so that'll increase our blood flow. I'm sorry, bad. I tried to draw, but I'm horrible. My son would be disappointed in my artistic ability. Okay, auto-regulation. Auto-regulation is nice. It's autopilot. You don't have to worry about it. It's dependent on whatever the metabolic activity is going to be of those tissues here. And so this puts the tissues in kind of like the driver's seat here. So when tissues start to become more metabolically active, right, they are going to then cause these vasodilators to be released into the area, right? And so what will happen is we'll increase blood flow to the area, or if the tissue activity decreases, okay, the other effect will happen, okay, then they will be releasing less chemicals that will cause vasodilation, and so that will decrease perfusion in the tissues. So we'll see it like here, for example, oxygen, right, and certain nutrients. Oxygen is great because, right, when oxygen levels are going to be needed for cellular aerobic respiration, right, they will help, all right, with vasodilation. Carbon dioxide, right, for example, lactic acid, these are all byproducts for our metabolic processes. Hydrogen, we'll also talk about potassium much more in the renal system when we get into the urinary tract there. And what we'll see is, okay, with an increase of these, right, what will happen when we increase the waste products, that means that that tissue is pretty active, so we have to have vasodilation, right? And also, if our oxygen levels are decreasing because the tissues are gobbling it up because they need it to make ATP, and any type of nutrient like glucose, for example, fatty acids, anything that can be used to help with metabolism, if those levels start to decrease, those too will act as vasodilators and then help to increase blood flow. So this is based on that negative feedback system there. So easy to say, perfusion is going to increase, right? And as a result of perfusion increasing, right, we will get constriction of those tissues, right, to regulate the amount of blood flow that will occur. So I don't know if you've ever heard of reactive hyperemia, but this is what happens, right? Easy way to determine this. Look at your thumbnail and then press down on your thumbnail for about 10 seconds and then release it. Now you'll notice initially when you take your finger away from the thumbnail, you'll see it looks white or light in color. Then immediately it turns red. And so this is what reactive hyperemia is, a small example of it. But what will happen is we've interrupted the blood flow there. But then when we release the pressure there, okay, we're going to increase blood flow to that area there because we want to get all those nutrients, the supply of oxygen, anything else into that area. But at the same time, we get an increase in blood flow. It's going to wash away the wastes there. So that's just a nice small example of that. All right, so let's talk about inflammation. This inflammation is a normal process to the healing process. All right, usually it's going to be a result of tissue damage or part of the immune response. But it is a normal process here. Okay, so when we're dealing with inflammation, we've damaged our tissues. And what we'll see is, okay, if there's damaged tissues, we got to get the cleanup crew in there. And if it's damaged tissue because maybe you cut yourself or whatever, then we're going to involve the immune system. So with inflammation, we'll have damaged tissue. We'll have our white blood cells, our leukocytes, and we'll also have platelets there because if you did cut yourself and you cut a blood vessel, we got to stop the flow of blood. All right, so we'll see, okay, two important chemicals, histamine and bradykinin. Histamine we've talked about with mast cells, and also we briefly talked about it with the eosinophils, right? But histamine is a vasodilator. It's going to cause vasodilation because we want to increase the blood flow. Okay, so we've got to get all of our repair crew from your blood into the tissue here. So we'll see histamine being released. Bradykinin is going to cause the pain sensation, but it too is going to cause vasodilation of the arterioles there. So we got histamine working on that, bradykinin working on that, and so that is going to increase our blood flow to that area there. And then from our actual tissue cells themselves, we can get the release of nitric oxide, which is another vasodilator. So you see there's a certain pattern here. We're causing vasodilation. We're trying to get more blood to flow to that area, all right? And that's what we're trying to do to deal with this inflammation. Now also, right, depending on what we're dealing with tissue damage, we can get the opposite. We can get vasoconstriction to occur. So certain chemicals are going to cause that. Prostaglandins are a great example. Prostaglandin E is a great vasoconstrictor. Some of our thromboxanes. Prostaglandins and thromboxanes are what we call eicosanoids. And if you remember, eicosanoids fit in that classification of local acting hormones. Okay, and so their job is going to be to cause vasoconstriction. And when we're causing vasoconstriction, we're going to decrease blood flow, which is good because this is going to help slow down blood loss. And so we have to make sure that we're not bleeding out. Okay, I think I'm going to stop here for the class. Actually, that puts us at a good spot. I will send out more material here, all right, very, very soon. In fact, when I get this downloaded here, I will get that out to you.